Good evening. Welcome to my IVF Answers. We are back with our webinar session today. Hello, Dr. Esther Marbán is with us. Hello, Esther. How are you? Great to have you back. Again, it's been a while, but I'm glad you are back. It's always great to have you. Today's topic is, as always, an interesting topic, difficult topic, and I expect lots of questions as well. How have you been? Good to see you.
Hi, Caroline. Good to see you too. As usual, I'm really glad to have the opportunity of having, the chance of sharing some of I think one of the most maybe interesting parts of the reproduction. So, well, I hope that the chat is interesting for everyone. And of course, I expect many questions afterwards.
As always, I remember that we usually have long sessions with lots of questions. I expect nothing else today. So everyone remember that we are here to give you some tips, give you some answers, some advice. Of course, Esther is the best person to do so. She's the fertility expert at Clínica Tambre, located in Madrid, and she's here to simply guide you first, because we will start with her presentation on our topic, recurrent failures in IVF, and then we will go straight to your questions. So as always, I just want to add that you can put those in the chat so that Esther can answer them for you, and you can do it during the presentation now, later on, but don't hesitate. This is your opportunity to ask one of the best, definitely, doctors in the field. So don't hesitate, okay? And this is all anonymous as always as well. So I hope that you are encouraged enough to type your questions, and I think that we can go ahead with our mission and our topic today. Yes, Esther, are you ready?
I'm ready.
Glad to hear it. Let's go ahead. Here's the presentation, and I think we can start with this. And just let us know if everything is fine and working fine. I believe so, but just in case, let us know if you can hear us loud and clear, so we can begin. I think we can go ahead. Thank you so much.
Thank you, Caroline. Thank you. So as we were mentioning before, today's topic, I think, is quite interesting for everyone. We are talking about endometrial factor and recurrent failures in IVF. We will go through the diagnosis and the treatment for them. But first of all, we'll try to cover all those topics. As you may see, we are talking about the definition of endometrium and the importance of that. Also, the endometrial receptivity and the microbiome, the uterine factor, the definition of recurrent failures in IVF, and finally, the strategies for recurrent failures in IVF related to endometrial factor. So we are going to get focused on those topics. So first of all, let's define what is the endometrium and why it's so important. So the endometrium is the innermost layer of the uterus where the embryo implantation and the fetus development takes place. So due to the ovarian hormones, endometrium changes every month. So the estrogens produce a lining thickened to prepare the potential pregnancy, and finally the progesterone prepares the endometrium for the pregnancy, supplying the lining and stimulating the glands grow to nourish the early embryo. But why is the endometrium so important in fertility treatments? So we were saying before that is the place where the embryo implants. So we need a good endometrium to give our patients the highest pregnancy rates. So we need a good endometrium in terms of the thickness of that, and also we need always a triple line aspect. That means that the endometrium has like 3 different lines before we plan the embryo transfer. So we know that that aspect and a good endometrial thickness is absolutely necessary to achieve better chances of implantation. So we can get to that stage in different kind of treatments. So when we perform an IVF cycle, due to the hormones we give our patients, the endometrium will have, we try that the endometrium has a completely triple line aspect and a good endometrial thickness. It can also be achieved in a natural cycle. Also, when we use estradiol and afterwards progesterone, and in patients that do not have a good endometrium, we need to change the strategy. and we use maybe gonadotropins. Sometimes we also use aspirin, sildenafil, or other therapies with the idea of having the best endometrium possible. So apart from the aspect the endometrium has, it's also important to have a receptive endometrium. So when we talk about the endometrial receptivity, we need to get focused in what we call the window of implantation. So the window of implantation, as you may see, is known as the period of time when the endometrium has the best conditions for the embryo implantation. And we call that a receptive endometrium. So it's the moment when the endometrium is more receptive for implantation, which means that if and we do the embryo transfer, it should be a higher chance of implantation if the endometrium is receptive. So we know that this period is short and depends on the effect of estrogens and progesterone in the uterine lining, and it may vary between women. So we know that between 25 to 30% of patients might have the window of implantation displaced, and it may be different. So if we do the embryo transfer always at the same time, it may mean that not all the endometriomes will be receptive then. So when we check that window of implantation, we are able to personalize the embryo transfer much better, which means that some patients may need more hours of progesterone to make the endometrium receptive. So the progesterone is the hormone that will make the endometrium receptive, or even less hours of progesterone. So we can calculate when to do embryo transfer in the best moment for each patient. But in addition, it's also really important to get focused in what we call the endometrial microbiome and the potential chronic endometritis. So the endometrial microbiome is known as the totality of microorganisms that the endometrium has. So the normal microbiome of the endometrium is dominated by a bacteria called Lactobacillus species. We know that some pathogenic deviations in the Lactobacillus species we should have may play a role in terms of failure of implantation, and in the end may play a role in infertility. So an abnormal endometrial microbiome has been associated with implantation failure, pregnancy loss, and adverse obstetrical outcomes. So in the last years, we have been very conscious about how important the endometrial microbiome is. So in the past, we didn't know so much about that, and we of course weren't paying the attention we should to that part of the, let's say, of the endometrial lining. But at this stage, we know that it's quite important to also get focused on that, to examine it when needed, that part of the endometrium, and of course find a proper treatment in the event that we find any kind of abnormality. So in this slide, you can see that we can do the biopsy. In the end, what we do is a biopsy of the endometrium. We take some part of the tissue of the endometrium. Of course, we don't do it at the same time as the embryo transfer, so it will be in a separate moment. So what we normally do is we try to do it as close as the embryo transfer as possible, with the idea of having quite updated situation of how the endometrium is doing before the embryo transfer. So the idea is with a small biopsy of the endometrium, which is not excessively painful, it's just uncomfortable. That biopsy can be taken at the consultation. And in that biopsy, we are able to check first that window of implantation that we were mentioning some minutes ago. And we are also able to do diagnose of the endometrial microbiome. So we are checking the bacteria that endometrial contains. So we are going to find potential chronic infections that in most occasions are completely asymptomatic. And if needed, we can find the best treatment for those infections. So the idea is checking first if there is any kind of chronic infection, and then we can also check if the bacteria that patient has in the endometrium is the one that we recommend, which is the Lactobacillus species 1, or if there is, of course, a chronic infection, the bacteria that patient has would get, the Lactobacillus will go down, will be reduced, and then beneficial bacteria will be growing there. So it could be a disbalance between both species. So we need sometimes to add a proper antibiotic to remove the infection first, and then we need to restore the environment the uterus should have. and it's normally done with probiotics, oral or vaginal ones. It depends on the case. But apart from how the endometrium is, which is one of the most important parts, we also need to do a good assessment of the uterine cavity and the uterine shape. So we know that the normal uterus is like, well, at least the cavity is like a triangle, but we may have some kind of uterine malformations. So those uterine malformations can be diagnosed with a normal ultrasound, but what is like more, let's say, recommended to be done is a 3 dimensions scan in which we are able to do like a reconstruction of the uterine cavity, so we can measure the shape of the shape of the cavity. We can also see the distance between the tubes, for instance, that the cavity has. So we are going to be able to see if the cavity is in the best condition, is wide enough to allow a pregnancy. Apart from that, we can also do a classification of the different kind of malformations if it's needed. It's also possible, apart from the ultrasound, to do a magnetic MRI, a magnetic resonance, to try to also have information that way. It's true that at this stage is much easier and also cheaper to do a 3 dimension scan. It's not very difficult to be done. Of course, it has to be performed with in expertise hands, but it's pretty easy to perform, and we can get much information about the cavity and the uterus. And sometimes, even though with a normal scan we can see a completely normal endometrium, sometimes after having done that 3D scan, we can decide if the endometrium was, the cavity and the uterus was completely normal, or if we find any alteration that has to be solved before. So one of the reasons why sometimes endometrium doesn't grow as it should could be like a potential malformation in the uterus, and at the same time, some malformations can increase the failure of implantation rate and also the miscarriage rate. So because of that, when we are talking about reproductive patients, and especially patients with failure of implantation, we need to get focused in the uterine factor. So of course, we are not talking today about the embryos. We are not talking about the other factors such as immunological ones or whatever. We are just getting focused in the uterus. So it's really important to give our patients the chance of having a good uterine assessment to try to increase the chance of implantation as much as possible. So we are quite used to having patients that have done previous embryo transfers, maybe in other clinics, and then they found out that they had an issue in the uterine cavity. So at least in our opinion, it's really important to have a good uterine assessment to try to increase the chance of implantation as much as we can. So when we talk about the implantation, that procedure is quite, let's say, it's a physiological procedure, but it's not very easy. So when we say that a patient has a failure of implantation, has been classically defined as the failure the failure to achieve a pregnancy in women younger than 40 years old, after having transferred at least 4 good quality embryos, considering both fresh and frozen embryo transfer. So this is the classical definition. But to be honest, we don't wait for so long at this moment. So currently, when we are transferring very good quality embryos in a patient, and that at least 1 or 2 of those embryos fail, we start talking about failure of implantation. So this is not the strict definition of that, but at the same time, we need to consider that due to the techniques we are using at the laboratory at this moment, and also considering that many patients undergo egg donation treatments, so we are transferring really good quality embryos and really high potential implantation rate embryos. We don't wait for so long to say that a patient has a failure of implantation. So when we talk about the embryo implantation, we need to consider that this is the procedure by which the embryo on blastocyst stage, so on day 5 or day 6 stage, joins the maternal endometrium to carry on its intrauterine development. So as you may see in the slide, there are like different stages. So first of all, the embryo has to go out from the capsule that the embryo has. Then it has to get closer to the endometrium. It has to join, and then it has to, there's like an invasion of that embryo in the uterine lining. So all those steps have to be followed step by step from the beginning till the end to make an embryo implant. So it's not so easy just to do the embryo transfer and leave the embryo there. Then after that, there are many steps, as you can see, that have to be followed before the implantation happens. So we were saying some minutes before that the implantation procedure involves the endometrium and also the embryo. So we need, first of all, to have a good endometrium and also a good embryo. So the embryo quality is really important in terms of implantation. So you will see it later that if we don't have a good quality embryo, the chances of implantation, even though the patient has the best endometrium possible, will be reduced because of that quality of the embryos. Apart from that, the embryo quality is related, of course, to the gametes quality. We call gametes eggs and sperm. After that, we also need to consider the technique and to do the embryo transfer in the proper moment. And finally, it has to be like a proper dialogue between the embryo and the endometrium. So it has to be like a connection between both of them. And of course, we need a suitable luteal phase support. We were saying what is a failure of implantation, but it's also very important to consider what is not a failure of implantation. So when we are talking women that is older than 40 years old, if the embryos have not been tested, and of course, if we are not talking about egg donation, so if the woman is older than 40 years old and the embryos have not been tested for the aneuploidy abnormalities, the potential chance of implantation with those embryos are pretty low. So even though we are transferring embryos and they have, let's say, an optimal quality, the potential implantation rate with those embryos is quite reduced. And because of that, we shouldn't consider that patient as a failure of implantation one. Apart from that, if we are also having some medical conditions such as hydrosalpinx, which is when the tubes are full of liquid, are also patients with endometriosis, we know that those patients may have a decreased implantation rate. The reason is that endometriosis is known that can affect, apart from the egg quality and the egg quantity, it can also affect in some cases, especially the patients with adenomyosis, which is like a different kind of endometriosis that affects the uterus. So it's known that that adenomyosis may play an important role on implantation, which means that if a patient suffers from that kind of issues, the chances of getting pregnant could be reduced. As we mentioned before, a low quality of the embryos will also be related to a failure of implantation. So if we are transferring low quality embryos, it's, the chances of getting pregnant are pretty low. And because of that, we don't consider that as a failure of implantation. Same happens if we have some problems in the uterine cavity. So something that is inside the uterine cavity, we can have like polyps, fibroids, or a scar, whatever adhesion, whatever we find in the uterine cavity may affect implantation. So if a patient suffers from that kind of problems, it's likely that the embryo won't implant. It's not because any other factor. Of course, it may happen that that patient may also have other factors, but we are talking a main factor, for instance, a polyp, which is a condition that we know that will affect for sure the implantation rate. And finally, if the endometrium has not grown as we expect, or the endometrium doesn't have, let's say, a good aspect or a good thickness, so the endometrium hasn't developed as it should, of course, we can't consider that that patient is having a failure of implantation, because in this case, the main reason is that the endometrium is not good enough to allow an implantation. So apart from talking about what is a failure of implantation, we also should consider what different strategies we may have for recurrent failure of implantation in IVF related to the uterine factor. So as I mentioned, we are not talking about the embryo or other potential factors. We are just getting focused, as the topic of today is, we are just getting focused in the endometrium and the uterus. So first of all, as I was explaining before, we need to do an exhaustive endometrial and uterine assessment. So currently, it's not acceptable to just try and try and try to transfer embryos, like losing embryos with no other, let's say, option. So we need to do, first of all, a good endometrial assessment and uterine assessment. So it's possible to as well to know more about the uterus. We can do a 3 dimensions scan. As I mentioned before, it's a non-invasive test, and it's like pretty useful for us to know more about endometrial cavity and also the uterine shape with that 3D scan, which is, as I mentioned, pretty easy to be done. In some cases, we recommend doing a hysteroscopy, which is a surgery, it's a minor surgery in which we are inserting a camera to see the uterus, and we can take sample if it's needed. So it's the gold standard, and it can also help us in treating a patient when it's needed. And finally, as I mentioned before, the MRI. In addition to that, let's say initial test, we can also recommend some additional ones as a endometrial test. As I mentioned before, that will give us information about the receptivity of the endometrium, and also will give us a good assessment in terms of the potential chronic endometritis and the microbiome the patient has. So, apart from doing a good and exhaustive assessment, it's important to personalize the embryo transfer when it's needed. So, it's true that many patients prepare their uterus like in a, let's say, in good conditions with almost all the treatment. But it's also possible to find, and we are pretty used to having patients that are having issues with the thin endometrium. So sometimes we can prepare the endometrium like as we normally do with just estradiol and progesterone, which is called substitute cycle, which is, let's say, like the gold standard. But it's true that in some occasions we also do what we call the modified natural cycle, in which we take advantage to the production of natural hormones the patient has, and we just monitor how the follicle grows, and at the same time as the follicle grows, the endometrium gets ready. So it's a really good option, of course, for patients that are having kind of regular periods, not for menopause women. Sometimes when we don't get to the stage we want, we need to use some different strategies. Some of them include the use of gonadotropins, the same that we use to stimulate the ovaries. In this case, we are not having the goal in our mind of stimulating the ovaries. We are just trying to make 1 or 2 follicles grow. And at the same time as they grow, we know that those follicles will start producing estradiol, and in the end, it may have an effect on the endometrium. So with low doses of gonadotropin, sometimes it's more than enough to get a good endometrium. But as I mentioned before, sometimes we are trying to fight against what we call the thin endometrium, in which we need to add more and extra medication to try to increase that thickness. So sometimes we need to use sildenafil, which is Viagra, also aspirin, vitamin E, pentosyphiline. So we have like different strategies for thin endometriums that are not so infrequent to be found. And to be honest, day by day, we see more patients with those kind of issues in the consultation. And we need to get to a treatment that is completely personalized for them to give them the highest chances of implantation, which is not easy. So apart from the classical treatments, in the last couple of years, we have been used let's say, quite a new treatment, which is called the PRP, or the platelet-rich plasma. So that PRP has been used in our clinic in 2 different kind of patients. The first one, if patients with recurrent failure of implantation, and also patients with thin endometrium, which are the ones that sometimes are pretty difficult to deal with those thin endometrium. So the PRP is an infusion that we do with the patient's blood sample. So we centrifuge the blood sample and we isolate the results from the serum. So we get like a collection of platelets concentrate and we keep it. So we do 3 different intrauterine infusions before the embryo transfer in different moments of the cycle, and we always measure the endometrial thickness to check if it's doing any effect. That procedure is not painful at all, so we just do an infusion in the uterus, and it's very similar to a IUI technique, so it's not actually very painful. And we are getting, we are studying how it's going, and we are getting some good results, so we are happy with those, even though, as I mentioned, we are talking that sometimes a thin endometrium is quite challenging, even for us, because considering that maybe we are not having any malformation of the uterus, we don't know exactly why some patients do not have a good endometrium, and we are trying to push endometrium grow as much as possible. Sometimes it's not easy, but with the new techniques we are using, we are getting better results. But it's true that sometimes it's something quite worrying for us, because not all patients get to the stage of having the perfect endometrium we wish. So as the conclusion, as I mentioned, it's really important to have an accurate diagnosis, and specific tests are absolutely essential for a correct assessment and proper treatment of failure of implantation. So we need to have a multidisciplinary approach. As we mentioned, it's important. We are just getting focused today in the uterus, but it's important to have a good endometrial thickness, good endometrial assessment if needed, a good, a proper examination of the uterus if needed, with a 3D scan or MRI when it's indicated, and same happens with endometrium. So sometimes we need to do further tests to know if there is any kind of chronic endometritis or any other problems that may affect implantation. So as I was explaining to you before, the endometrium is extremely important for fertility patients. So a good endometrium may increase the implantation rate, apart from other factors. If the endometrium is not looking as we need it to be, it's true that we may have a decreased implantation rate in those patients. So an endometrial assessment and tailored treatment of patients within endometrium also play an important role in personalizing the transfer of the embryo transfer protocol, and increasing the implantation rate for these patients. So as I mentioned before, apart from doing a diagnosis, it's very important to have a very tailored and personalized treatment in patients with thin endometrium, because in the end may have that failure of that implantation rate decreased. So we need to find the best treatment for those patients. And thank you very much. So I'm open for your questions.
Brilliant as always. Thank you so much for your presentation, introduction to the topic, but of course explaining what can be done. And as always, Esther, as you can see, plenty of questions are already here. So just to let you know, we have around 30-40 minutes for those, so probably won't be able to answer all of them, but of course we will definitely forward those to the team at Clínica Tambre. I'm sure they will be happy to help you out, because I know that there will be more questions coming up during our Q&A. So I just wanted to let everyone know, but of course we will now go for your questions. Let me start with the first question that we have here. Some of them are quite similar, but of course I will try to get them all. We will definitely try to answer them all, answer them for you. So the first question is, so how is adenomyosis diagnosed? What protocol for transfer would be best for someone with adenomyosis?
Well, the adenomyosis normally is diagnosed with MRI or also with 3D scan normally. So it's true that sometimes with an hysteroscopy we can see signs of adenomyosis, but in our experience, the 3D scan is the one that gives us like let's say a better diagnosis. When a patient is diagnosed with adenomyosis, we know that it may increase the failure of implantation rate in those patients, and it's also possible to increase the miscarriage rate. So because of that, we always try to reduce those complications if possible, In our case, we normally use the capeptyl for at least 3 months to try to lower the impact of that adenomyosis. Some other protocols also use letrozole. The idea is like reducing the activity of that adenomyosis in terms of the potential, let's say, negative effects it may have for implantation.
Okay, thank you. I believe that answered your question. Of course, if there are any follow-ups, remember you can still go ahead and ask. So let me go to the next question. So how high would you recommend natural or modified, natural or medicated frozen embryo transfer in women over 40? Any difference in success rates?
Well, the only reason why I would suggest undergoing a substitute cycle is if the patient is not having regular periods. If the patient is having regular periods, we can do a natural modified cycle, which is pretty comfortable for the patient. The results are exactly the same in both cases. So if the patient is having regular periods and is willing to come to maybe 2 to 3 scans to the follicular monitor, it's completely feasible. So both of them would be fine.
Okay, again, thank you. Let me have a look. Okay, as I mentioned, there are plenty of questions. So now we will have a background story. So I had 3 abortions naturally, 3 IVF, and overdonation with getting positive. Some male factor was there, but not for overdonation. I have high NK in blood test. Which test do you recommend to do?
Well, today we are trying to get focused in the uterine factors. So in this case, I would suggest like at least doing a 3D scan or even an hysteroscopy, right, to check the cavity of the uterus. And considering that that patient also undergo egg donation, I assume that the embryos had a good quality. But if it's having any issue with the NK cells, it would be at least advisable to get a consultation with an immunologist specialized in reproductive issues to, well, try to also have a proper treatment in that case.
I'm just looking at some. No, okay, everything is fine. And now we will go to the questions in regards to implantation. There were very similar ones. Let me just try this one. Can implantation be achieved where the where the endometrium is not trilaminar?
It may be achieved, but the chances are quite reduced, right? So same happens with the lining, I mean with the thickness of the endometrium. So it's true that we always try to get like the goal of 7 millimeters. So it doesn't mean that if the patient has 5 millimeters, she won't get pregnant. Of course, she can get pregnant if the endometrium has a triple line aspect. So our goal is having, if possible, a triple line aspect and thicker than 7 millimeters. But if the endometrium has a good aspect and also, but it's not triple line, the chances are, let's say, are reduced. So we try always to get that triple line aspect, which is the most important part.
Okay, thank you so much again for that. I'm just looking, but so one more question in regards to implantation, a window of implantation actually. Is there still a window of implantation when you have menopause?
Yeah, because in the end, when you're having menopause, it doesn't mean that you can get pregnant because, of course, you can't use a natural cycle. We are using a substitute cycle. So, with that substitute cycle, due to the estradiol effect and also the progesterone intake, that window of implantation will be there. So, in the end, it's not a matter of having regular periods or not. Of course, this patient without having regular periods can get pregnant naturally, but with a treatment. So, we are giving her the hormones in a thermal way with the idea of making the endometrium be receptive. So because of that, of course, she can get pregnant and she will have like a receptive endometrium for sure.
Okay, thanks a lot for this. Okay, now we will go again with a bit of a background story. So I need to show this to you. It's a bit of a longer one, so let's give it a minute here. I had 2 natural miscarriage at 7th week, 3 biochemicals, pregnancy through IVF. My endometrium was always checked before the transfer. It was 8 to 9 thickness. My embryos are all good of good quality. All 5 embryos with AA and AB quality. All tests are normal. Hysteroscopy was also okay. Scan done. No adenomyosis. Always I end up in miscarriage, checked also immunology, it's all okay. And with my husband as well, including sperm motility, sperm quality, what can be done? Will PGTA help in my condition?
Well, at least the most important information for me in this case is knowing the patient's age.
Of course.
Because, I mean, if the patient, of course, is older than 37, 38 years old, the main reason could has been the embryo. So even though the uterus seems to be fine, also the quality of the embryos is fine, sorry. And also let's say that the immunological factors are also being excluded. In that way, if the embryo is not healthy because of age and the potential risk of having some chromosomal abnormalities, the risk of having another miscarriage is high. So the main step should be like knowing the age of the patient, and of course doing the PGTA. I guess that I think that it may help in that patient.
Okay, if you can get the answer to us, but of course, I think it's pretty clear when it comes to that. So let us know as well, of course. But I think we can go ahead with the next question, and let me just have a look. And I'm not familiar with this shortcut. So before we go to this question, we have this in the chat. What are LADS? If you can explain to us. This is the second question, Esther. And there's a shortcut used at the end. So if you can just explain this to us, we will be able to go back to this question. And now I will just switch to the next one. Okay. Yeah. So we answered this one. Sorry. This is again a question, a short one. So what do you consider? When do you consider uterine surrogacy for endometrial factor? I know in Spain surrogacy is not possible. So it's not.
Yeah, well,
Something
regarding
you
that
can.
question is true that even though in Spain it's not possible, it's true that some patients may have a clear indication for that. So especially patients with, for instance, really thin endometriums that are completely not responded to any medication, maybe patient with very small uterus, also patient with many fibroids that are, making the endometrium completely abnormal in terms of the shape and the volume of that. So this could be like the most like the main indication for surrogacy, even though in Spain it's not possible, as you all know.
Yeah, of course. Thank you.
Yeah.
Crystal clear again. So of course there might be, it might be still suggested. Obviously, there are other countries where it's possible. I get it. Of course.
Absolutely.
Thank you.
Absolutely.
Okay, next question. So how effective is ERA tests? As I hear, your window can change each month depending on your cycle.
Yeah, it's true that the ERA tests and endometrial tests are, let's say, controversial. That's completely true. So according to the research, it's supposed that the endometrial, if we follow exactly the same protocol to prepare the uterus, the window of implantation should not change so much, but it's true that it may change. What our data suggests is that we have been using the ERA test and similar ones for years, and it's true that we are getting pretty good results. In the end, when a patient gets pregnant, it's very difficult to know the main reason. We know that window of implantation may help, but it's not the only factor we should get focused on, right? So as I mentioned, that endometrial test, especially the ERA one, is quite controversial. There are many research that says that it's completely useless, and some others say that, that can be quite useful for a certain group of patients. So in our opinion, it's true that it may help. It's not the only factor, but according to the data, it seems that the endometrium shouldn't change so much in the following months after performing the ERA test.
Okay, again, thanks a lot for that. Now we will go to a short question from Teresa. How often does mild adenomyosis affect the uterine lining?
Well, it's true that we are, let's say, I think that because of the techniques we use, we are diagnosing adenomyosis, let's say, day by day. It increases the number of patients that suffer from adenomyosis. Not all adenomyosis may affect the patient the same way. Of course, we are having a mild adenomyosis where the joint between the endometrium and the myometrium is not affected. The potential risk of having any issues because of that are not extremely high. but at the same time, we need to consider also the patient's background. If it's the first embryo transfer, maybe we don't need to treat it. But if the patient has failed several times, sometimes we need to consider that it may be a potential factors to consider. It doesn't mean that it's going to be the main one, but at least it may affect for sure. So in that way, it's also important not just to get focused, okay, that patient has adenomyosis or that patient doesn't have adenomyosis. We need to have like a different approach, or at least a more, let's say, like a different perspective, with the idea of like just knowing, apart from the diagnosis, also knowing the patient's medical history and putting everything together to find the best solution for those patients.
Okay, thank you. And just to clarify, yeah, Hema has gotten back to us regarding this question. She's 37, right? 37.
Okay, so in that way, and also considering all the transfers he has done, I think that doing the PGTA could be a good option. Apart, it's true that even though the sperm seems to be fine, I mean, sometimes also we need to add some other additional tests in the sperm to also know more about that. So in the end, I think that a patient that has tried several times with several miscarriages, I think it's time to change the perspective and try to add some additional tests as the PGT, as we were saying.
All right. Brilliant. Thank you a lot. Okay, now I will go to the question with this. Let me just find it because I have also the explanation of what I was looking for. I just need a minute to see if it's this one. Sorry. It's just many questions today. Sorry about that, but here it is. So I have had so naturally conceived. However, since then I have had 11 failed embryo transfers, 4 of them with donor eggs. I have had endometriosis removed, endometrial test done, ALICE test repeated to make sure endometritis was removed. I have had every test done, and my only issues are low LADS, and now we have the answer for that. Let me just go here. Just need a second. It's right here, I believe. Apologies.
Yeah, I think that there is a question here that
I saw it, and now I'm just going
it was like
at the
leukocyte
bottom.
body detection.
Yeah, that's correct.
Yeah. So yeah, in this way, we are not, this is not a test that we normally perform, right? The same happens with them. In the question, I think that someone was asking about the lymphocyte immunization therapy. So, as I mentioned, it's like something related to immunology. And apart from that, I mean, our immunologist is not very, like, it's not doing those tests, right? So in that way, I mean, I can't add anything more because we're not using those tests currently.
Okay. We understand, of course, here. Thank you for that. Now, let me go to our next question. There was a question about ERA tests here. So, I have had 2 embryo failures using IVF. My consultant has recommended diagnostic hysteroscopy. Would you advise getting one? And I already had ERA test and corrected everything there when it comes to microbiome, right, etc.
Yeah, so I think it's a really good idea. As we mentioned, it's really important to have a good assessment of the uterine factors. So apart from other factors, as I mentioned, we are not talking about the embryos, and so we are trying to discuss the potential uterine factors. So I think that undergoing an hysteroscopy is a really good idea to have a good diagnosis of the endometrium and also the uterine cavity.
Okay. And now we will again go to this question about endometriosis. So when it is recommended to investigate for issues like endometriosis only when symptoms happen or when failed embryo transfers, when there's failed embryo transfers without symptoms of endometriosis.
Actually, we say both of them. So it's true that when a patient comes to the consultation suffering, I mean, because of the infertility problems, by that time, we should also need to do like a proper diagnosis of that patient. Sometimes it's true that they can be completely asymptomatic and there could be very small signs of adenomyosis or endometriosis in the scan. So it's a good way to start with and just say, okay, we suspect that there could be and maybe a slight endometriosis that can also affect fertility. So in the end, we need to quite well to find the best strategy for those patients. So as I mentioned, some patients didn't know that they have that issue before until we do maybe a high resolution scan or a 3D scan in which we can see both of them. So of course, if a patient suffers from failure of implantation, it's really important to do some tests in the uterus to exclude those factors that in the end we know that may play a role.
Okay. Thank you. And now we will go to this interesting question. If you can help with that, how and when will AI play a role in determining the probability of each couple's chances of getting pregnant? Anything you can?
Which, sorry, could you repeat
Sorry,
that,
how
please?
and when will AI play a role,
Uh-huh.
right? Yeah. I'm sure you are already maybe using AI in the labs, perhaps, but
Yeah, yeah,
anything
exactly.
else?
But I think I prefer not to give my opinion because I don't know, to be honest. I don't know where the AI will, in which point
Mm,
will be like very important, or maybe it's no so important, but I guess it will play a role for sure. For sure, and laboratories actually and currently playing an important role. But I don't know in our daily practice as doctors when it will be like taking an important part of that.
of course, there's
It's
still
I
time for
really
it,
don't
but I'm
even,
sure at some point it's
but at
something
some
that,
point it will get to that for sure, for sure.
yeah, of course. I mean, nowadays you even are using like donor when it comes to donor matching, etc. It's still it's available. It's out there. It's just not in every part of this. Let's say not yet.
Yeah,
I guess. Sure. Thank you
absolutely.
so. Okay, and how do you feel AI helped you in your daily practice? Do you use it? There's another question here, so if you can perhaps comment
As
on
I
that.
mentioned, I mean, as a doctor, we are not using it yet, but I guess that at some point we will start using it. I don't know exactly when and how, but I'm sure that it will be affecting or maybe helping our daily practice for sure,
Mhm,
for sure.
of course. Thank you a lot for that. A little bit of topic, but we still can answer, right? So thank you so much. And
Yeah.
now we will go to the next question. We are back on track, okay? When it comes to the topic. So, what are common factors that impact 40 plus women IVF success during implantation? So, would you recommend fresh or frozen transfer for 40 plus? How many days old of embryo? And is scratch actually increasing the chance of success? A few
Well,
questions in one more.
patients, yeah, patients that are in their 40s, the main reason for a failure of implantation is the embryo itself, apart from other factors. So we need to have or at least we should recommend those embryos to be tested first to maximize the option of getting an euploid embryo. And then if the embryos are healthy, of course, we need to think in other factors. But the main step and the most important one is the embryo itself. So in that way, and also considering the risk of having non-healthy embryos, as I mentioned, the idea would be testing the embryos first. And I think the other question was
Let me
apart
just.
from if I recommend it as fresh or frozen
Yeah,
cycle.
sure.
So
Yeah.
I mean, if we are checking the embryos, I would say 99% of times we freeze the embryos and then we do the embryo transfer afterwards after having the results from the geneticians. So in that way, if they are planning to do that technique, I think that they will be using frozen embryos. And regarding the scratching, it's true that it's also quite controversial. Some data and some research has found a slightly increased implantation rate, but it's
Mhm.
true that in many other papers, any benefit has been found. So in the end, it depends on the protocols each clinic wants to follow. We don't perform routinely the endometrial scratching, but it's true that some patients want to do it and we perform it for them. But I mean, we are not, let's say, like using it like daily
It's not a routine, right? To actually go ahead with it.
for us.
Okay, sure. Thanks a lot for that one. Quick question: does the embryo glue work?
I'm afraid it doesn't work. I mean, I know that the name, that media, that culture media has is quite, let's say it's a good commercial name, but it doesn't have anything to do in terms of implantation rate. So it has been proven that
Mm.
the embryo glue is not increasing the implantation rate, even though some patients want to do it wants to use it anyway, which is fine
Mhm.
from us. But we always explain to them that there is no any data suggesting that it may increase implantation rate.
Crystal clear again. Thank you. We will go to PRP, okay, right now. So when is the optimum time to do a PRP for endometrial thickness before doing an embryo transfer? Should it be the menstrual cycle before the cycle when you intend to do the transfer?
Yeah, we normally perform it in the same preparation cycle when the embryo transfer takes place. So we start the preparation, and in between 5 to 7 days after having started with the endometrial preparation, we do the first infusion. Then 2 days afterwards, we do the second one, and 2 days later, we do the third one. And then we plan the embryo transfer. So we, according to our protocols, we do it in the same cycle when the embryo transfer takes place.
Okay, thank you. Supplements. So what is your view on using supplements like vitamin E, L-arginine to improve endometrial thickness?
Mhm. Well, actually, vitamin E has been has proven that it may increase the implantation, sorry, the endometrial thickness. The same happens with the aspirin and also with pentoxifylline. So there are some data suggesting that also the sildenafil Viagra may increase like the vessels flow in the uterine in the uterus, and because of that we sometimes use it. Even though of course it shouldn't be used in all patients due to the potential side effects it may have. So all the vitamins try to increase in the end, like the flow in the uterus, and also the, let's say, like the aspect the cells have to make them like bigger and to make the endometrium thicker than it was before. But of course, we should consider that the effect won't be so, let's say, visible. So of course, we know that we try to use different strategies, but I don't expect that a patient that, for instance, has, let's say, a 4 millimeters endometrium, using those medication would get to 10 millimeters. It shouldn't be like that, and I think it's not realistic. But at least we can try to increase a little bit, maybe 1 to 2 millimeters the endometrium, and make it like more, let's say, beneficial for implantation.
Okay. So now the question, what are the difference of the endometrium between women 40 plus versus younger women?
Well, endometrium shouldn't be so affected by age. So it's true that even though we know that the ovaries have quite a short period of time in life when they work perfectly fine, I'm happy to know and to tell our audience that endometrium is not so strict in terms of timing. So the perfect example that we have is the with menopause women. Even though they have been on menopause for years and years, we are able to make the endometrium grow good, have a good endometrial thickness, and have good chance of implantation after using the therapy of hormones. So the main reason why an egg donation treatment works, apart from the egg quality and also the embryos we transfer, is that the uterus has, as I mentioned, like more time to react to the medication and to give the patient good chance of pregnancy, which doesn't happen with the ovaries. So the uterus is more flexible in terms of reacting to the medication and responding to that. And that's the reason why, even though a patient is not having regular periods, maybe the patient is getting old baby in their late 40s, the chance of implantation are the same if the embryo we are transferring is a healthy and good quality one.
Okay, and we answered the first part of this question because the question was does the endometrium age? You answered that. So there's a more history here. So my recent transfer, it was 7.6 on the day, donor egg sperm, but previous transfers is much larger despite similar medication plan. Anything you can add?
Well, as I mentioned, first of all, is, I mean, if a patient has constantly, let's say, kind of a thin endometrium, the first step is doing a good diagnose treat the potential factor that may be affecting that patient, and then undergoing a new treatment. Maybe the endometrium is completely fine, the cavity is fine, the uterus looks fine, we don't have any infection in the uterus. If so, maybe we need to change a little bit the strategy, add different kind of estradiol, maybe plan a natural modified cycle. So we may have different strategies to try to increase the chances of having a better endometrium.
Regarding fibroids, so can intramural fibroids cause thin endometrium? What happens if your doctor feels the fibroids should not be removed? Can you still have implantation?
Yeah, I mean, it's true that we know that the submucosal fibroids are the ones that are affecting to implantation in almost all cases, so they should be removed. Regarding the intramural ones, it's also controversial depending on the location of the fibroids, and also depending on the size of the fibroids. In many occasions we decide not to remove them, because in the end we are also opening the uterus, and it can also have an impact in terms of timing and also in implantation. So if the fibroid is not excessively big, if the patient maybe just have done one embryo transfer, I would suggest keep on trying. Of course, if the fibroid starts growing, or if it's located in a place that can be affecting at some point the cavity, in those cases we should consider a surgery to remove it.
Okay. Brilliant. Again, thank you so much. And let me just go for the next question. We still have time. We still have lots of questions. Maybe you can help with this here. I've had 3 failed implantation embryo transfers of all good quality and euploid embryos, had endometritis, did CD138 and Emma Alice tests, but it was cleared most recent tests. Transfers still failed. Anything else I should try?
Yeah, I mean, apart from those endometrial tests, a good assessment in terms of hysteroscopy or a 3D scan, and also assuming that the embryos are fine, also maybe doing further tests on the embryos, and finally having a complete examination in the immune system and clotting system. So in the end, when we're talking about implantation, it's like everything should be connected. If one part fails, it's difficult that the other ones will work.
Okay, there is actually more information here. So let's have a look, okay? Because again, there's quite some details. So this is the same patient as before, just now. So what would you suggest for 26-year-old with 3 failed embryo transfers, cleared endometritis, original male factor diagnosis, all embryos day 6 for BB, euploid, Emma Alice, doctor didn't do ERA test, no fibroids or polyps, ultrasounds have looked good. It doesn't think it's silent endometriosis.
Well, I would suggest like the ERA test first. Also, any kind of test to check the uterus. So even though it seems that the cavity is fine because of the ultrasounds, and so I could suggest an MRI or an ultrasound, a 3D scan. And apart from that, as I mentioned, maybe adding some additional tests as the immunological ones or clotting ones.
Okay, hope that helps, of course. And there are some more questions with details. So let me go again to this one. So I'm 36 now. My husband is 45. 4 years ago, I had my IVF cycle. After the embryo transfer, doctor told us that we were having twins. And after a week, he said that embryos are not growing. So the IVF was unsuccessful. What is the reason why embryos don't grow? What is the solution? Anything you can help with here?
Yeah. So the main reason could have been just the embryos. So that patient was 36 years old, so she wasn't excessively, old. But even though the embryos were growing, at some point they can start growing. The main reason is the potential chromosomal abnormalities the embryos have. So, of course, we don't know 100% sure, but it could be the main reason for that.
Okay. And we will be slowly finishing. So if you have any questions that you would like to ask, go ahead, do it now. Okay. And let's have a look. So does having a TAC cervical suture affect implantation in any way? I will show you this here.
Not really, not really. I mean,
Mhm.
if the surgery has been done in the cervix, which is completely out from the endometrium, it shouldn't affect at all. It's true that sometimes due to a cervical surgery, the
Mhm.
cervical trajectory, let's say, closer and narrower than expected. So it may affect in terms of how difficult or easy could be the embryo transfer. But if we're talking just in terms of implantation, if the embryo transfer goes fine, it shouldn't affect at all.
Okay. Again, Dorian, thank you a lot. Is there any cutoff of higher endometrial thickness? For example, after what many millimeters, right? Is it considered not good?
Yeah, I would say around 14 millimeters or
Mm.
and over. I mean, of course, if this is a perfect triple line endometrium and so on is 14 point something, well, we should discuss if it could be good enough for us. But I would say maximum 14 millimeters.
Okay, crystal clear again. More than 14, not good, of course, but thank you so much for that. And now we will go to Nal and her questions, two of them. Is it possible for someone to not have the good or bad bacteria in the uterus? I did an endometrial test with iGenomics. This was the result. And we don't see the result, okay, but yeah, I guess, okay, no question. How long will it take to build back the good bacteria using probiotics, and what are the best probiotics to use? Anything you can add on that?
Well, actually, there is no like there are no best and worst probiotics. It depends on the bacteria we need to restore. So, depending on the bacteria the patient has the lack of, we need to restore some of them. So, there are like many different species of lactobacillus. Some probiotics, oral and vaginal ones, contain different species of lactobacillus. So, depending on on the lactobacillus species that the patient doesn't have, the laboratory recommends like using some probiotics to restore the good environment. So normally, of course, it depends on each patient, but I would say like at least 2 to 3 weeks of treatment should be enough to get the let's say the lactobacillus back to the endometrium. But it's also true that if we have an infection, we need to treat it and then use the probiotics. But maybe an antibiotic should be also recommended in those kind of patients if of course an infection has been found.
Yeah, thank you so much. And I believe there were like two questions left, but I think that we've answered lots and lots of questions. Great session. Thank you guys for sending those. And I believe it was helpful. Lots of useful information we got today from Dr. Esther. And two questions. So, first one, short one about supplement CoQ10. So, what do you think about
Mhm.
that? And how can it help?
Well, the CoQ10 may play a role, like it's supposed to help in the egg quality, but it may also help in the endometrium. It's not one of the ones that we use as a routine practice, as I know if we are when we are having a thin endometrium patient. But I mean, as all the supplements may help, but I wouldn't say that is like the main factor to make an endometrium grow for sure.
Okay, brilliant. Thank you so much. And now we will go to the question about PRP. So, is there a
Mhm.
difference between PRP infusion and PRP injected with hysteroscopic subendometrial PRP injection, right?
Yeah.
Instrument. If so, which one is more effective for uterine lining thickness?
Well, it's true that the infusions we normally do in the consultation are, let's say, less invasive. So the hysteroscopy means that it's like a surgery. In some case, it has to be done in the operating theater. Sometimes it can also be done in the consultation. Of course, it's more painful because we are using like the device of the like the camera that has to go inside the uterus. So it's true that some protocols recommend using the PRP infusions like behind the endometrium. In our clinic, we use like the normal infusions with no hysteroscopy. is quite, well tolerated to our patients. So in the end, they haven't been found major difference between both techniques. So in the end, it depends on the protocol each clinic follows. As I mentioned, we use like let's say, the less painful and most simple one, and we are getting good results.
All right. Again, thank you so much. And we've got one more question. And sorry, last question. It's okay. I think we can still handle this if you can have a look. So does N-actylin cysteine, I'm sorry, I'm not familiar with this one, help in recurrent miscarriages? Are you able to tell us?
The last data we have is that it's not affecting so much in terms of failure of implantation and recurrent miscarriages, right? At the same, as I mentioned, when we are talking about those topics, we need to consider many factors. So in the end, it's that almost every day, some like new molecules start appearing, saying, well, it may affect, it may help, but in the end, it hasn't been proven that it may play an important role.
All right. Again, thank you so much. And I believe that was our final question. But of course, remember, if you have any questions, you can always get in touch with Clínica Tambre whole team. I'm sure they will be happy and able to help you out with any queries you have. And Esther, as you can see, plenty of thank yous, plenty of questions. First of all, so thank you so much, everyone, for also your time and for your questions. And as you can see, I want you to see some of your some of the comments here. Great presentation, very informative session. So what can I say? Thank you so much for organizing an excellent presentation. Okay, I think we can still answer this one. So does your clinic offer free initial consultations?
Yes, we do. Yes, we do.
Definitely. So all you need to do is just get in touch directly with the team, and they can help you, I'm sure. Brilliant. Thank you so much, everyone. It's been a great session, and I'm not surprised because every time we have a webinar with Dr. Marbán, this is the truth. We have lots and lots of questions, right? So thank you so much, everyone. It's always a pleasure to be here and see this. And I just want to, before we finish, I want to also invite everyone for on the 7th of May. So next Tuesday at 7 p.m. London time, we will talk. Sorry, 6 p.m. London time. Apologies. We will talk about how to prepare and how to increase your chances. I mean, for embryo transfer, how to increase your chances. And if you would like to find out more and ask your questions, join us. There will be 3 doctors from different clinics, so you can join us and ask any of your questions. There is no presentation this time; it's just Q&A. So you can join and you can find more information on my IVF. And of course, there is a link where you can sign up. So I can only encourage you to do so. And thank you, everyone, for today. Esther, as always, it's great to have you. I'm looking forward to some more events. And everyone, have a lovely evening. And also one more thing before I let you go, I would like to encourage you to fill in our survey, because right after we finish, you will be redirected to our survey. Please let us know about this webinar, but all webinars that we do. What is your feedback? What is what you liked? What maybe you didn't like? We would love to hear from you, as simply you want to improve. And yeah, that will be it from me. Esther, thank you so much. Have a great evening and see you soon as well. Take care.
Thank you, and I'm really happy that it was helpful for our
I am sure.
audience. Thank you
It's
so much.
been great
Thank
to
you so
have you
much for the
indeed.
comments.
Thank you. Take care. Bye.
Bye bye. Thank you.